We have the first speaker within AUNG, who is here as the first speaker, and we'll talk to you about cataract and glaucoma. Thank you very much, Tim. Thank
you. Good morning, everyone. Thank you for attending today's symposium. And I'd like to thank the organizers for inviting me on this very broad topic of cataract and glaucoma. I have no relevant disclosures. I come from Singapore, and these are some pictures of Singapore, and from the Singapore National Eye Center, which is the main eye hospital in Singapore. So overview, today I'll give us brief concepts of handling cataract and glaucoma, but I'll divide it into open-angle glaucoma and angle closure glaucoma because the approach is a little bit different between the two. So for open-angle glaucoma and cataract, of course, you have several options, doing phaco alone, phaco with a MIGS, or phaco with trabeculectomy and mitomycin C. And you have to look at the disease factors, such as severity, the IOP control, number of medications, as well as patient factors, such as tolerance, the compliance, and the quality of life. And certainly for mild diseases, you would consider doing a phaco alone versus a phaco mix. And in this example of a patient with OHT, and certainly you would think of doing either a phaco alone or a phaco mix procedure. So MIGS is a recent, maybe over the last 10 years or so, where it's a group of surgeries where you have less destruction of the target tissue, maybe less in terms of aggressiveness of surgery and rapid post-op recovery. But the IOP reduction is modest. And there are various ways of looking at MIGS, whether it's through the meshwork or Schlemm's canal, through the suprachoroidal space or subconjunctival space, and each have different pros and cons. And some of them involves the use of devices, and others do not need devices. But there are three big pivotal MIGS studies where we compared phaco MIGS versus phaco alone. And one was using the Hydrus, the second one was using the CyPass, and the third one was using an iStent inject. And all three studies were FDA trials where they recruited all in excess of almost 400 patients with phaco MIGS, compared to about half the size for phaco alone. And you can see here the mean deviation was about -3 in all groups, as well as the number of medications were about 1.7 pre-surgery. And the washed-out IOP was in the range of 24 to 25 millimeters of mercury. But what's very interesting in all these trials was how phaco alone was consistently shown to reduce IOP by 5 millimeters of mercury, showing you the effectiveness of phaco alone in POAG and OHT. You can see here that all three trials showed similar effect of phaco alone. However, of course, if you looked at the effect of the MIGS, it was slightly higher, about 2 millimeters higher for the Hydrus, and about 1.7 for the CyPass and 1.6 for the iStent inject. And so certainly there's an option for mild cases of POAG and cataract. For more advanced cases of open-angle glaucoma, of course, you need to think about whether phaco MIGS is sufficient or whether you need to combine it with a trabeculectomy with mitomycin C. And this is the gold standard in terms of glaucoma surgery, in terms of IOP lowering in the long term. And the problem, however, there's some complications of doing augmented trabeculectomy with mitomycin C, including risk of hypotony, bleb-related infections in the long term, as well as failure. So these are potential issues. We move on now to angle closure glaucoma, and this is an important form of glaucoma, especially in this part of the world. And in angle closure glaucoma, the predominant mechanism in many cases is pupil block, and that's why you do an iridotomy in the early stages of the disease. But we also know that when you do an iridotomy, some angles do not open up, and this is because the iridotomy only treats the pupil block element, and there are other mechanisms involved in angle closure, including the lens, the ciliary plateau iris, and others. And the lens is really a major factor in angle closure glaucoma. You can see here the effect of removing the lens in angle closure. It opens up the angle well, and it lowers the intraocular pressure. And this is a patient with a very large lens vault. In this kind of cases, there's no point doing an iridotomy. You should straight away take out the lens. And remove the lens will also remove the pupil block element. So currently, for management of angle closure glaucoma, we also look, the first question we ask is there a significant cataract? And if yes, should we consider a phaco alone? And this should be considered for milder cases of angle closure with not so severe visual field loss or optic nerve damage, and perhaps with less medications. But if you have more severe cases of ankle-closure glaucoma, we need to consider, should we combine it with a trabeculectomy and mitomycin C? And there have been several trials looking at this topic of between phaco and phacotrabeculectomy. I'd like to quote studies from the Hong Kong group by Clement Tan. He did 2 trials, one for medically controlled ankle-closure glaucoma, which were the more milder cases, and one for the medically uncontrolled ankle-closure glaucoma. And both trials showed that phaco alone did very well in terms of IOP lowering, but there was, of course, a slightly higher IOP lowering efficacy with phacotrabeculectomy. You can see here the results both in the medically controlled group as well as the uncontrolled groups. So phaco alone is a very good option as well for ankle-closure glaucoma, but for more advanced cases, you may need to add it with trabeculectomy and mitomycin C for the higher IOP lowering as well as the fewer medications and post-op on follow-up. What about acute ankle closure? As you know, it's an emergency. It's a very common medical emergency in many of our accident emergency departments. And even for acute ankle closure, there have been trials looking at phaco alone versus the laser iridotomy. And I'd like to quote the one trial from Singapore and one from Hong Kong. And in both trials, they did a very early phaco within the 2 to 3 days of presentation of acute ankle closure. And you can see the Hong Kong study here. At 1 year, you can see the results were much better in the phaco alone group, at least in terms of IOP lowering. There's much less people who needed medication. Only 3% needed medication in 1 year, compared to 46% in the laser iridotomy group. And the Singapore group also showed similar results at 18 months here. You can see 2 years here, the Singapore group also showed almost 99% success for the phaco group compared to 60% in the LPI group. So definitely, we would definitely do an early phacoemulsification for acute ankle closure as well. But when do you do it? I think in the trials, we did it in the first 2-3 days, but nowadays we probably wait for a while to let the eye settle down, reduce inflammation, and do an early phacoemulsification maybe within a month of the attack. Let me just delve into 2 quick issues about ankle closure, glaucoma, cataract extraction as well. One is goniosyncytiasis. In the cases of acute ankle closure with lots of synechiae, should you do a phaco-goniosyncytiasis? And we did a trial in Singapore comparing phaco with phaco-goniosyncytiasis, and we were surprised to find that the effectiveness of goniosyncytiasis was not superior to phaco alone. You can see the complete success rate was similar, and IOP change was also similar in terms of phaco-GSL with phaco alone. And showing you that although anatomically it may open up the angle, the efficacy-wise, the IOP reductions was similar. And Tanuj Dada in Delhi also did a trial comparing phaco with phaco-GSL, also found similar success rates of phaco alone with phaco-GSL. So perhaps, even if you break the PAS in case of ankle closure glaucoma, the threshold may not be functioning, and so it may not be effective enough in terms of IOP lowering. What about phaco mix for ankle closure? He has very limited data so far. There have been many case reports and case series for phaco mix, and certainly for the devices that you place in the Schlemm's canal, there's risk of occlusion. But recently, there's been a trial going on in China, led by Zhang Xulan, where she compared phaco-goniotomy and goniosyncytiasis with phaco-trabeculectomy. And they found really effective, good results for phaco-GSL goniotomy. And certainly, this is something we should watch out for future data. The last issue is that of clear lens extraction, and there's an EAGLE trial, which is a multi-center trial, which looked at cases of clear lens extraction for ankle closure glaucoma. And they found at 3 years that the clear lens extraction group did slightly better in terms of quality of life as well as IOP lowering compared to laser iridotomy. And certainly, we are moving towards earlier lens extraction in ankle closure glaucoma, but perhaps not so much clear lenses. I think clear lenses is perhaps slightly more aggressive approach, and you should discuss this approach with your patients. But remember, these are ankle closure can be difficult cases, and there are risks of complications. And certainly, if you do a clear lens extraction and you develop cataract complications, this will be very bad for your patient. And certainly, you need surgeons who are experienced and able to handle such cases. So in summary today, I've given you an overview of the management of cataract and glaucoma. So for open-angle glaucoma and cataract, I think you have options of phaco alone, phaco mix, or phaco-trabeculectomy. And the amazing results of the mixed trials showed the effectiveness of phaco alone of at least 5 millimeters of mercury lowering in open-angle glaucoma. But phaco mix had additional efficacy about 1 to 2 millimeters. And certainly, you reserve phaco-trabeculectomy for the more advanced cases. For angle closure, we know the importance of lens in angle closure, and certainly we consider phaco alone as a primary treatment for many patients with angle closure glaucoma. Of course, those with the more severe cases, you may combine that with a trabeculectomy and mitomycin C. Consider doing earlier lens extraction for acute angle closure, as well as in other cases which are other cases of angle closure. But remember, phaco in extraction in angle closure eyes can be technically challenging with high risk of complications. Finally, I'd like to talk to you about fellowship programs at the SNEC. We do accept international fellows from all different subspecialties. We do have paid fellowships, usually at least for 1 year. And also like to invite you to Singapore next year for the Asia Pacific Glaucoma Congress, as well as the SNEC 35th anniversary in the 24th to 26th July next year. Thank you for your attention.
Thank you very much. A very interesting and instructive presentation, Tim. I would like to make you a couple of questions, because we have some time for discussion. This is a session for practical indications. So the first one is, as private glaucoma is the most frequent comorbidity that happens to be in cataract surgery, when do you consider that should be mandatory, indicated, combined surgery, and when is not? In other words, when you have no doubt either to do with a glaucoma surgery or to do yourself, being a cataract surgeon, the surgery. So in main indications. And the second question is, which is the main technique that should be in the hands of a cataract surgeon? Some of these techniques are for glaucoma specialists, while others are not. So which ones do you recommend as more appropriate for cataract surgeons? Thank you, Tim.
As I said earlier in my studies, phaco alone is a very effective IP lowering effect in all forms of glaucoma, open angle glaucoma as well as angle closure glaucoma. And certainly you could consider phaco alone as a first-line option in many patients with coexisting cataract and glaucoma. And you can see the IP lowering is very decent. For open angle glaucoma, about 5 millimeters of mercury, and for angle closure, even higher in many cases. And certainly, but the more advanced cases, then perhaps the cataract surgeon should consider referring the patient to glaucoma surgeons to consider either combining it with a trabeculectomy, or even a phaco mix for the milder cases could be considered, if they are proficient in mix.
Thank you very much. Any question? Nothing? Any question from the audience? No questions? Well, thank you for this very self-explanatory